Hello everyone, welcome to another conference about carcinoma of cervix and role of MRI in evaluation of cancer cervix. My name is Dr. Jeff. I'm a radiologist. So today's talk will discuss the role of MRI in evaluation of cancer of the cervix, and we'll also discuss the FIGO staging, which was updated in 2018, and all the updates that were incorporated on the recent edition and why they were important, and role of fertility sparing surgery and all the surgical options there are. So carcinoma cervix is the fourth most common cancer and the fourth most common cause of death related to cancer in women worldwide. So in terms of etiology, 99% of the cervical cancers are related to human papillomavirus infection, and there are around 100 human papillomavirus species that are available, and out of those 70 to 80% of the cervical cancer is caused by the HPV type 16 and 18 infection. Other weaker risk factors for cervical cancer are a patient who has a first degree relative who has cancer. Pregnancy before the age of 17 is an increased risk factor. Smoking, poor socioeconomic status, poverty, and immunosuppression is associated with increased risk of cervical cancer. These, however, again are lower, weaker risk factors but significant. But the most common cause and the risk factor is HPV infection, particularly with 16 and 18 type of HPV. The most common tumor is a squamous cell kind, and the second most common is the adenocarcinoma type of cancer. So in terms of assessment, the clinical size accuracy is really poor, like 60% based on physical examination. So MRI has a higher accuracy in terms of determining the size of the tumor, with 93% accuracy compared to within the 5 millimeters on histopathology. PET-CT plays an important role in evaluation because it helps us evaluate for any distant metastasis and if there is any lymph nodal disease. So in terms of evaluation, MRI protocol, these are the major sequences that are acquired during MRI. First, a large field of view T1 and T2 weighted imaging is performed that extends from the renal hilum up to the pelvis level. The goal of this sequence is to evaluate for any para-aortic lymphadenopathy, make sure there are no bone lesions in the abdomen and pelvis, and to evaluate for hydronephrosis, because if there is hydronephrosis, that's an indirect marker of pelvic sidewall infiltration. The next sequence is small field of view T2 weighted images. They are acquired at two orthogonal planes that could be most commonly axial and sagittal T2 weighted sequences, and then based off of those images, these small field of view T2 images, oblique axial T2 images are acquired. These are also small field of view images, and the oblique axial images acquired perpendicular to the cervix. It's important because that helps us evaluate for any parametrium invasion next to the cervix, because it's cutting the cervix at perpendicular angle. And oblique sagittal T2 weighted sequence is also acquired in line with the cervix, and that is important because it helps us evaluate if there's any endocervical extension or if there is any vaginal wall involvement of the tumor. DWI has an added advantage and is not necessary all the time, but it definitely adds value in difficult cases. And important thing to consider is the DWI also should be acquired in small field of view and in axial oblique plane, so that if there is any questionable area that we are not sure on oblique axial T2 weighted images, we can refer to the DWI weighted images. DWI weighted images increase the sensitivity and specificity of tumor detection and extension into the perimetrium. Dynamic contrast enhanced imaging is optional. It adds value, but it is not necessary for acquisition. Vaginal gel is important in patients who have such concern for upper vaginal involvement. Vaginal gel can help us delineate margins of the tumor better. So this is an example of a SAG T2 weighted image and an axial T2 weighted image. In terms of anatomy, you can see this is the uterus, which is retroflex. This is the sacrum for orientation. This is the urinary bladder anteriorly, and the uterus is retroflexed here. Identifying the regions is important. So this T2 bright structure here is the endometrial lining. This T2 dark structure here is the junction zone, and this T2 intermediate structure is the myometrium. It is important to understand where the cervix ends and where the uterus begins, because in terms of identifying patient candidates eligible for fertility sparing surgery, we need to identify the tumor extension, and the tumor should be greater than 1 centimeter from the junction of the cervix and the uterus. So accurate assessment of the cervico-uterine junction is important. It can be better identified by identifying these vessels. So these T2 bright structures that we see here at the level of upper cervix, they are better seen here on the axial T2 weighted images. And these T2 bright dots here, these are all the major vessels that are draining around the cervix. These are used as marker for identifying the junction between the cervix and the uterus. So if you draw a line right here at the level of these vessels, the part of the anatomy above is uterus, and the anatomy below that level is the cervix. Another important anatomic marker is bladder neck. So you see this is the urinary bladder anteriorly, and this is the bladder neck, right where the urethra begins. And if you draw a line horizontal at that level, the point where it cuts the vagina is a fair marker of distinguishing upper 2/3 of the vagina from the lower 1/3 of the vagina. It's important to distinguish if the tumor is extending from the upper 2/3 to the lower 1/3 of the vagina, because it is important. It changes the stage of the disease. So bladder neck can serve as a marker of distinguishing these two levels. All right, moving on. So this is the classification, 2018 FIGO classification. It has been updated since 2009, and we will discuss the differences, but we'll first go over the major stages of the cervical cancer. So stage 1 is the tumor when it is confined to the cervix alone, and that can be determined because the cervical stroma is T2 dark in nature, and if you can trace cervical stroma ring around the tumor, that is a fair marker that the tumor has not extended beyond the cervical stroma and has not gone beyond the cervical margin. Stage 2 is when the tumor extends beyond the uterus but has not involved the pelvic side wall or lower 1/3 of the vagina. Stage 3 tumor is when the tumor has extended beyond and has involved either the lower 1/3 of the vagina or pelvic side wall. Hydronephrosis also is suggestive of stage 3 tumor, because since we know that the ureters run in the pelvic side wall, and if the patient has hydronephrosis, that's an indirect marker that the tumor has extended and involved the pelvic side wall. And lymph node involvement has been included in stage 3 on the recent FIGO update. Stage 4 is when there is involvement of adjacent organs or any distant metastatic disease. So coming to the FIGO staging here, we can see there are two major changes. The first major change is distinguishing between stage 1B and 1 and 1B2 disease. So the tumor is less than 2 centimeters, it is classified as 1B1, and if it is greater than 2 centimeters and less than 4 centimeters, that classifies as stage 1B2, and greater than 4 centimeters is 1B3. So this is the recent update. The update is important because this clear distinction between 2-4 centimeter size is important in identifying patients eligible for fertility sparing surgery, which we will discuss subsequently. Another important update that was uh, included on the recent FIGO to 2018 classification was pelvic and para-aortic lymph node involvement. So pelvic lymph node involvement is classified as 3C1, and a para-aortic lymph node involvement is classified as 3C2 disease. It is important because it changes the prognosis of the patient and treatment which the patient is eligible for. We'll see how it changes in the subsequent slides. So this is an example. We'll go over a few examples of all stages of tumor and how they appear, and better understand the staging. So this patient presented with this mass at the level of cervix. So this is the SAG T2 weighted image. This is axial T2 weighted image. This is coronal T2 weighted image, and this is T2 fat sat image. So here we see this T2 gray tumor, which is present in the cervix. Again, we see it here in the cervix, and here as well, we see it in the cervix. Important thing to note here is you see this T2 dark lining all around the mass lesion on all the planes, and in none of the planes, we see that stromal lining has been broken by the tumor. So that suggests that the tumor is confined to the cervix alone and is consistent with a stage 1 tumor. Moving on, we will go to further reclassify these tumors as stage 1B1 tumor. So this is a 23-year-old woman who presented with abnormal cervical smear screening, and there was this T2 gray tumor that was identified. Since this is a young female, she could really benefit from a fertility preserving surgery. And since the tumor is small enough, this tumor is less than 2 centimeters in size and does not show any extension beyond the cervical stroma. This meets the criteria for fertility sparing surgery. So this is a DWI weighted image showing the tumor, which is DWI bright and has a corresponding ADC dark signal. So this is stage B1 tumor, less than 2 centimeters in size, localized to the cervical stroma alone. Moving on, we will see this. This is a 37-year-old woman who presented with intermenstrual bleeding. And here we see this T2 grayish tumor, which is centered in the posterior cervix. It's causing a local mass effect on the posterior wall of the vagina. However, as you can see, there's this T2 dark lining, and there is no break in the lining. There is no extension of tumor into the vaginal mucosa. So this tumor is localized to the cervix, but the tumor size is bigger. So it's bigger than 2, but appears less than 4 centimeters in size, consistent with a stage B1-2 tumor. This is an example of stage 1 B3 disease. The tumor is bigger in size. Pay attention to the size of the tumor. It's easily more than 4 centimeters in size. But if you pay attention to the margins of the tumor, it has this T2 dark thin stroma all around it. That suggests that the tumor is not infiltrating, has not broken out of the cervical stroma. So this patient is stage 1B3 disease. Moving forward, stage 2 disease. So stage 2 disease is, so this is a sagittal T2 weighted image. We see this T2 grayish tumor here, and that tumor is extending inferiorly along the anterior wall of the vagina here. Pay attention that the tumor is reaching up to this level only. And if we use our anatomical localizer and identify the bladder neck, which is right here, the tumor is above the level of the bladder neck. So this patient has stage 2A disease, and particularly based on the size, it becomes stage 2A2 disease. And since the tumor has not extended into the inferior vagina, lower 1/3 of the vagina, it's stage 2 and not stage 3. Moving forward, this is stage 2B disease. So this patient has this T2 gray tumor, and this tumor is causing local mass effect And there appears to be this mild edema or like some kind of T2 heterogeneous signal abnormality along the posterior wall of the bladder, and that may raise suspicion for tumor infiltration into the bladder wall. But if you look at a small field of view axial T2 weighted oblique images, though they have a better spatial resolution, and you can see here is the tumor here is present, breaking the cervical stroma lining posteriorly and laterally right here, but there is no break anteriorly, and there is preserved fat plane between the posterior wall of the bladder and the anterior wall of the cervix. So there is no tumor extension into the bladder wall as it appeared questionable on the SAG T2 weighted image. So we'll discuss stage 3A disease. So this patient presented with a dyspareunia, 58-year-old female, dyspareunia, pain with sexual intercourse, and blood-stained vaginal discharge. So here we see this T2 gray tumor extending inferiorly into the vaginal wall. And we can see this tumor is extending all the way down here into the lower vagina. If we recall our anatomical marker bladder neck that distinguishes upper 2/3 from lower 1/3 of the vagina, it has definitely extended below 1/3 of the below that line and is consistent with stage 3 tumor. Example of stage 3B disease. Stage 3B is pelvic side wall involvement. So this is a 50-year-old woman who presented with right flank pain and was found to have hydronephrosis. MRI was acquired, and on the MRI you can see this is the T2 bright tubular structure running along the lateral wall of the pelvis, and there is this abrupt narrowing in the lower pelvis, and that corresponds to the level of the tumor that we see on the axial T2 weighted images. So this is the T2 gray tumor, and if you pay close attention to it, I'll remove the marker here. If you pay close attention, there is this T2 dark lining of stroma, which is preserved posteriorly, but laterally that lining has been broken and the tumor has extended into the parametrium. And then there is this adjacent dilated tubular structure that corresponds to the dilated right ureter. So this implies pelvic side wall involvement since the ureters run in the pelvic side wall. Stage 3C1 disease is when there is pelvic lymph node involvement. So we'll first look at the primary tumor, of course. So this is the primary T2 gray tumor along the posterior margin of the cervix. And on the axial T2 weighted images, we see this T2 gray round lymph nodal mass in the left pelvic side wall. And then this tumor here shows heterogeneous T2 bright central signal, which likely represents central necrosis. To confirm, the patient underwent a PET-CT, and the PET-CT shows this hypermetabolic left pelvic side wall lymph node and then hypermetabolic right pelvic side wall lymph node with central low uptake suggestive of necrosis. Moving to stage 3C2. Stage 3C2 is when there is para-aortic lymphadenopathy. So this is a 29-year-old woman who presented with purulent vaginal discharge. So we will look at the SAG T2 weighted images here. So here we see this heterogeneous large T2 heterogeneous mass lesion centered at the level of cervix. And we can see this tumor is extending into the uterine cavity as well. And likely due to the local mass effect from the tumor, there is inadequate flow of the endometrial fluid contents, leading to fluid-filled distension of the endometrium. On the axial T2 weighted images at the level of cervix, this is the cervical mass lesion, and we can barely make out any preserved cervical stroma. The tumor has extended beyond the cervical stroma into the parametrium right here. And this is a coronal T2 coronal CT showing heterogeneous para-aortic lymphadenopathy right next to the aorta and the IVC. and the patient underwent a PET-CT that also shows this hypermetabolic para-aortic retroperitoneal lymphadenopathy that is consistent with stage 3C2 disease. Moving to stage 4A tumor is when there is involvement of adjacent pelvic organs. So this is a SAG T2 weighted image. Here we can see there's this heterogeneous T2 grayish tumor. And if you pay close attention, right here, there appears to be abutment of the anterior wall of the rectum. We cannot be sure if it is involved versus artifactual. So we go to the oblique axial T2 weighted image and see if the tumor is extending. So here we can see the tumor is extending posteriorly, has broken the cervical stroma right here, and is involving the adjacent wall of the rectum right there. And this T2 gray stuff is involving the tumor, is involving the entire wall thickness of the rectum right here, consistent with stage 4A disease. Moving forward, stage 4B disease evaluation, we will evaluate the primary mass first. So there's this heterogeneous lobulated mass at the level of cervix. It's extending into the endometrial cavity superiorly, and is large mass extending inferiorly into the vagina right here. And then anteriorly, the tumor is extending into the posterior wall of the urinary bladder. So it's a pretty aggressive, locally aggressive disease. And on the axial T2 weighted images, we can see dilated left ureter, and then there is enlarged right pelvic lymphadenopathy. Dilated ureter with transition point at the level of mass is suggestive of pelvic sidewall involvement. The patient underwent PET-CT, and we can see there's this hypermetabolic left supraclavicular lymph node. So with distant metastatic disease being positive in this patient, this becomes stage 4B disease. All right, a few pointers on lymph node involvement. So if the lymph node is greater than 10 millimeters in long axis, and or if the lymph node is greater than 8 millimeters in short axis with round morphology, that is considered positive for lymph nodal involvement. Other minor criteria that can help raise suspicion for lymph node involvement is lobulated or spiculated contour, if there is any capsular breach of the lymph node, if there is central lymph node necrosis. Coming to the treatment planning part of the presentation. So below 2B, the patients are eligible for surgical resection. But if the patient has 2B disease, that is parametrial invasion, or above, the patient needs to have chemoradiation done, that is non-surgical. So the rule of thumb that can be used is to be or not to be. So if the patient has to be, then and above, chemoradiation, less than 2B, surgical resection. So we can use that to briefly remember the treatment planning criteria. Exceptions to this rule exist. And if the tumor is greater than 4 centimeters in size and less than 2B in stage, the patient should undergo chemoradiation as well. Another exception is lymph nodal involvement. If the lymph nodes are positive and the tumor is below 2B, they qualify for radiation therapy with a field of radiation including the involved lymph nodes. Lymph nodal involvement is important because it changes the management in terms of radiation therapy field inclusion. Also, it is a predictor of prognosis. So if there is no lymph nodal involvement and the patient has 2B disease, the 3-year survival is 85 to 90%. And if there is lymph nodal involvement and the disease is still 2B, the survival drops to 50 to 55%. So that's why in the recent upgrade, lymph nodal metastasis has been included in stage 3 disease. Treatment options have been decided, and now the patient undergoes for surgery. So if the patient qualifies for surgery, radical hysterectomy and bilateral central oophorectomy with sentinel lymph nodal sampling is the treatment of choice. Some patients may qualify for fertility preserving surgery if the patient is young, and if these criteria are met, the patient can undergo fertility preserving surgery. So this criteria apply only to squamous and adenocarcinoma. They do not apply to the other lesser common variants such as small cell neuroendocrine types. The tumor should be less than 2 centimeters in size. The distance between the tumor and the internal os should be greater than 1 centimeter. The invasion of the tumor into the cervical stroma should be less than 50%. So these are the three main criteria that are important to be met before the patient can be considered for fertility preserving surgery. And of course, there should be no parametrial invasion or metastatic disease. So what are the fertility preserving surgeries that the patient can undergo? So conization is the most common, which is the lesion is removed with the underlying transformation zone. Trachelectomy is another fertility preserving surgery procedure. There are two kinds of that. Simple trachelectomy involves removal of the cervix, and radical trachelectomy involves removal of the cervix and the parametria. There are a few pitfalls in imaging that needs to be discussed. So the post-biopsy inflammation can often present as false positive for parametrial invasion. So oftentimes these patients present with clinical symptoms of bleeding, dyspareunia, and purulent discharge. So they go to the office and they undergo biopsy, and usually MRI is performed for staging. So patients who come to us for scanning already have had a biopsy, and sometimes the biopsy related inflammation can make it difficult to evaluate the tumor. So this is an actual T2 weighted image, and here we see this T2 heterogeneous signal that is extending into the parametrium on both sides, and it is indistinguishable from the tumor involvement, particularly because this is the tumor, but we cannot distinguish if there is a tumor involvement or there is local inflammation that has extended into the parametrium. This is a SAG T2 weighted image, again, of the same patient, showing this susceptibility artifact, that is air, suggestive of recent biopsy. So DWI plays a very important role in such cases. As you can see here, the DWI bright signal is present involving the cervical mass, but there is no extension of DWI bright signal into the parametrium to suggest tumor involvement. And the corresponding ADC map also helps, and the corresponding ADC map does not show any dark signal in the parametrium to suggest tumor extension. Another pitfall is bullous edema, which can show as itself as a false positive for bladder invasion. So this is an axial T2 weighted image. So this is the tumor right here, T2 gray, and it is abutting the posterior wall of the bladder on this T2 weighted image. And then there's this subtle T2 gray signal along the posterior wall of the urinary bladder. And then again, we did a SAG T2 weighted image, and we on this image we see there is this T2 gray signal, but the posterior wall of the urinary bladder is maintained. So that is suggestive of non-involvement. But the best way to evaluate is oblique axial T2 weighted images, and the oblique axial T2 weighted image shows this T2 gray structure. The cervical stromal lining is maintained. It is broken right here, but there is no evidence of involvement of the bladder. So preserved stromal lining, no extension of tumor beyond the stroma, and no evidence of bladder can be seen in this oblique T2 weighted image. And this is the end of our presentation. Thank you so much for attending.